Chapter 10. Here we will talk about principles and practices of rehabilitation. This is in your text starting on page 153. First, we want to define what rehabilitation is. This is a goal-oriented process that enables people with acute or chronic disorders, including those with physical, mental, or emotional disabilities or impairments, activity limitations, and participation restrictions to identify, reach, and maintain optimal physical, sensory, intellectual, psychological, and or social functioning levels, and 2. Focus on existing abilities to facilitate independence, self-determination, and social integration. Here's a true or false statement regarding rehabilitation. And here's the answer with the rationale. When we look at the rehabilitation team, know that you want to have a interdisciplinary team approach, especially when it comes to rehabilitation. This takes a team of people. You as the nurse cannot do everything by yourself. If indeed you do take on the role as planning their total care when it comes to rehab, you then take on the role as a case manager, as said before. So you want to know what role you're encompassing when you are taking on total plans of care, especially when we look at rehabilitation. So you want to know that the patient and their family members or caregivers are a part of the rehab team as well. Of course, you're going to be planning care for this patient, so you want them to be able to adhere to the plan, so you want to include them while you're actually doing the planning. Don't just make a plan for the patient and not include them, because then the problem that you'll run into is them actually adhering to it when they're home. You also want to involve your physicians, your occupational therapists, physical therapists, social workers, of course, like I said, your case managers. You may also have, speech therapists and things of that nature. So make sure you have your team, and note that it is a continuous process. It requires active participation by the patient and their family members. And it is goal directed. So we're not going to just integrate or implement rehab without a goal in mind. Of course, we're working toward maximizing independence. As the nurse, you want to affirm that the patient is an active participant and recognizes the importance of informal caregivers in the rehabilitation process. You also want to develop a therapeutic and supportive relationship with the patient and their family members. Coping with the disability, fostering self-care, identifying mobility limitations, and managing skin care and bowel and bladder training are areas that frequently require nursing care. You, as the nurse, will act as a caregiver, educator, counselor, patient advocate, a case manager, and also a consultant. So you will wear many hats, especially when it comes to the rehabilitation team. Here's a question asking who's the key member of the rehabilitation team. And here's your answer. It is the patient. That's the most important person. And there's the rationale. And now we'll look at patient emotional reactions to disability. The The patient and family experience emotional reactions, and we have to be ready for this, especially if it is newly diagnosed. Losses precipitate grief responses, and they go through the stages of grief. If you need to familiarize yourself with those, go ahead and look those up, your 5 stages of grieving. Reactions may include disorganization and confusion, denial, depression, anger, regret, and finally they'll go ahead and accept it. But they may slip back into regretting or being angry, and this is normal, so we have to understand that. And you know that these reactions may subside, they may reoccur, and you have to educate the family members on this as well. And then we want to go over some coping abilities and methods to help both the patient and family members cope. And those methods will vary greatly. When we look at the functional capacity assessment, you want to look at those activities of daily living. You want to get them back to their independence if at all possible. We want them to be able to care for themselves. And instrumental activities of daily living, those are the more complex things, such as going for grocery, meal preparation, shopping, household management, cleaning up, finances, and of course transportation. So you want to know the differences between the two. Instrumental activities of daily living versus your activities of daily living, like your bathing and eating, toileting, stuff that would be on your Maslow's hierarchy of needs. When we look at assessment of functional ability, of course, you want to have that functional independence measure and see how well they're actually going to be able to function on their own. And some other disease-specific tools used to assess the patient's functional ability. You have the PULSES Profile Barthol Index, as well as the Patient Evaluation Conference System. So just briefly look over those and familiarize yourself with that as well. I do want to back up briefly in your text on page 155. Just briefly look at those areas of specialty rehabilitation. You may have noticed some of them within some of the healthcare facilities you've been in, but those are just some of the specialty areas of rehabilitation that I do want you to just briefly look at. When we look at some nursing diagnosis of those with disabilities and entering into rehab, one of the major ones that may be used is self-care deficit, related to being unable to bathe oneself or do the daily hygiene, dressing, grooming, feeding, or even toileting. Goals for that would be, individualizing it, of course, for the patient and their families, getting back to that self-care, or at least self-care with assistance, and of course, we want the patient to be satisfied with that actual level of independence. We don't want to overexert the patient too fast or push the patient too hard. Interventions for those goals, you want to foster those self-care abilities, motivate those patients, see what drives them to be independent. Most people have that internal motivation where they want to get back to being able to do what they did before the disability actually affected their life. So most people have that intrinsic motivation to get back to their normal independency. You want to also be able to help patients accept any limitations that they may have, because some patients, depending on the disability that they do have, they may not always get back to 100% of being independent. When we look at outcomes, these are some common outcomes, especially when we're looking at that self-care deficit. If they're able to demonstrate bathing and hygiene, dressing and grooming, feeding themselves, or either being fed with assistance, toileting independently, or even toileting with assistance or those assistive devices. Nursing strategies for teaching those activities of daily living. Of course, you want to demonstrate use. You want to see, first of all, what your patient knows and if they know how to use it. Some people will tell you that they know how to use these assistive devices, and that is just to get you out of the room. So make sure you assess their knowledge, assess their readiness to learn. If they're angry and not really accepting the fact that they have a disability, that might not be the ample time to actually teach them how to get out of the bed to the bedside commode. They're not listening and they're not in the mood, so you have to assess the patient first and see when we're talking about education. Also, identify those resources, especially when they go home. They won't be in your care forever, so of course we want to identify those community resources, or at least get the case manager or social worker involved so he or she can get those resources set up for the patient. And you also want to demonstrate how to access transportation if they are going to be driving, or even if someone else is driving, how to get in and out of the vehicle if they have a disability limiting their mobility. So when we look at nursing strategies promoting mobility, of course you want to go ahead and go through your nursing process just as you would with anything else, and assess your patient first and foremost. Look for positioning, maintaining that muscle strength, ambulation, and of course assisting those patients. Here's a diagram that points out some areas susceptible to pressure ulcers, and this you will see with your older population, your population that is in those assisted living facilities or even group homes that have mobility issues. We want to make sure that we are assessing them for those pressure ulcer spots, turning them frequently if need be, or having them get up and move around if they're able to do so. When we look at the risk factors for development of pressure ulcers, of course, the number one thing is immobility. So those patients who are bedbound and they are not able to get up, or those patients that we do get up and sit them in the chair, they're still at risk for those pressure ulcers. Of course, those that have impaired sensory perception or cognition, they may stay in one spot all day, or they may create a friction area that will cause that skin breakdown. Also, decreased tissue perfusion and nutritional status. Again, talking about friction and any increased moisture. So that then goes back to your immobile patients who aren't able to get up, or they have decreased cognition and they may defecate or urinate on themselves and they're not being cleaned frequently. This too can be a risk factor for a pressure ulcer. Here's an illustration here of shear and friction. And then we want to assess for the prevention of those pressure ulcers. Of course, you want to do a thorough head-to-toe assessment, making sure that you look at the skin, evaluate their mobility. If they have delayed mobility or cognition, you want to ask the family members or caregivers how often are they moving, who's helping them move, are they in one spot for longer than 2 hours, are they creating friction on those problem areas, and things of that nature. We want to evaluate the circulatory status. Are they having poor circulation in the lower extremities, upper extremities? Do they have any cardiac problems that would suggest this? You want to also look at their neurologic status. Another thing you can evaluate is their nutrition and hydration. We want to make sure these patients are eating a well balanced meal and staying hydrated. And the last thing you want to look at is the Braden scale, and usually this is built in to each computer charting system now, where you have to chart on your patient at least once a shift a Braden scale, and it gives you a number telling you if your patient is at low, medium, or low, moderate, or high risk for a pressure ulcer. Most oftentimes, if your patient is at risk for a pressure ulcer, it will automatically put in a consult for wound care management. So you want to make sure you are doing this per hospital protocol and assessing your patients properly. Looking at interventions for preventing those pressure ulcers, of course, relieving the pressure, positioning the patient, minimizing that moisture as much as possible, and improving mobility and nutrition. When we look at care and treatment for the pressure ulcers, we first want to look at the deep tissue injury, and we'll go through the stages very briefly. We won't go too much in depth with these stages when we talk about pressure ulcers, just because unless you're going to be the wound care nurse, you won't really have to deal with the staging of these wounds. So in the next few slides, we'll go through the staging of pressure ulcers. I just want you to briefly review them. First, looking at tissue injuries, then moving onward to stage 1 pressure ulcers, and just pretty much know the difference between them. Not so much what you have to do to treat them, but just how they stage them. And these are all found in your text on page 174. So here it defines the stage 2 ulcer and what you'll look for. It's actually telling you how to clean it and what dressings to use. Here looking at our stage 3 and 4. And again, like I said, unless you're planning to be a wound care nurse, you won't really be treating or addressing these wounds. Most of these patients have wound care consults, and wound care nurses come to clean or debride or change the dressings. Some of them will have on what we call a wound vacuum, and you will see that when you do enter into the healthcare facility. So if you do not know what these devices are, by all means, make sure you're asking your healthcare providers, and they do not mind explaining or telling you about the information. It is neat to actually see it in person versus in your textbook. And here's a question regarding collagen synthesis. And the answer with the rationale. And now we'll talk a little bit about urinary incontinence or urinary and bowel continence. Of course, do not restrict fluids unless your patient is on a fluid restriction. Make sure they're drinking adequate amounts of fluids per day, even if they're getting IV fluids. Most oftentimes, unless your patients are dehydrated or have some type of electrolyte imbalance, they'll restrain from putting them on IV fluids. So try to get your patients to drink at least 2 to 3 liters a day. This can be quite difficult, especially for your patients that are older. You want to teach them about habit training, going to the bathroom every 2 hours, if not more frequently. Avoid those indwelling catheters. We do not want those infections and UTIs. You may have to do intermittent catheters, but then that also puts the patient at risk for infection as well. Teach them about Kegels. Then when we look at bowel continence, we want to look at the consistency in implementing a plan. That is essential. Toilet patients at the same time daily, especially if they're telling you they have a bowel movement every day around 5. Do not wait till 4:59 to try to get them up to the bathroom, because they may have an explosive episode, or they may just release. So you want to make sure that you talk to your patients about their urinary and bowel continence, especially if they have normal cognitive functioning. Of course, positioning, you want them to have a high fiber diet, and of course, again, the 2 to 3 liters of fluid a day, and we always want to increase and encourage physical exercise and activities. Looking at home and community-based care, when planning the approach to self-care, the nurse must consider the individual patient's knowledge, experience, social and cultural background, level of formal education, site, and their actual psychological status. The preparation for self-care must also be spread out over the course of the recovery period, and it must be monitored and updated regularly as the patient masters aspects of the self-care. Note that preparation for self-care is also highly relevant for informal caregivers of the patients in rehabilitation. There is a nifty chart in your text on page 178, 10-8, that goes over managing therapeutic regimen at home. And this is an example of a home care checklist. Again, with the home and community-based care, of course, they want to demonstrate mobility status, skin and bladder, bowel care, their community resources, and access to transportation. And if you look in your text, all of those are listed in the home care checklist. So you want to make sure that the patient and caregiver understand how the checklist works, promote those positive attitudes and feedback, and family members need to know as much as possible about the patient's condition and care, so that they do not fear the patient when they actually return to the home, because they will ultimately be caring for the patient in the home and getting them back to that independent, steady state. And before we end in chapter 10, I did just want to briefly go backward a little bit. Briefly review the material that goes over, crutches and assistive devices, ambulation. Not so much remembering 4-point versus swing when those, but just remembering what it actually is, your orthosis versus your prosthesis, and preparing for ambulation. And this all starts in your text on 162 when it talks about ambulation, whether they're using a cane, a walker, crutches, if they have a prosthetic device. There's also a good tenure text on page 166 that goes over nursing actions involved in using assistive devices. And then lastly, I want you guys to look at the chart 10-6 in your text on 167, which goes over the risk factors for pressure ulcers. That is very important. It is not only in your slide, it is in your text as well, and I do want you to take a look at that, because you'll be assessing patients quite frequently for pressure ulcers, and you want to know what those risk factors are and how they can ultimately affect your patient care and the overall plan of care. And with that said, this concludes Chapter 10, which goes over principles and practice of rehabilitation.